I'm the Director of Research and Innovation here at Georgian College, and it is my pleasure to welcome you to today's Lunch and Learn. To kick things off, I'd like to start with the land acknowledgement. And while all of us, for the most part, are working remotely, and with some folks going into campus as needed, but I would still like to acknowledge that our facilities is located in the traditional land of the Anishinaabe people. The Anishinaabe include the Odawa, Ojibwe, and Potawatomi nations, collectively known as the Three Fires Confederacy. We are dedicated to honoring Indigenous history and culture and committed to moving forward in the spirit of reconciliation and respect with all First Nations, Métis, and Inuit peoples. Fantastic. So today it is my great pleasure to welcome our two presenters today, Dr. Stephanie Atthill, and we've got Deb Witmer with us. Stephanie has worked at Georgian College since 2016 and has been a registered nurse since 2007. And she's currently teaching in our Bachelor's of Science nursing program. Her areas of expertise include adult medical surgical nursing and postpartum care. Stephanie completed her PhD in nursing education from Western University in 2015, and she actually presented some of that work at a previous Lunch and Learn several years ago, and I had the pleasure of sitting in that one, and where her dissertation research focused on nursing informatics competency development within undergraduate nursing curriculum. Deb began her career at Georgian in 2001 and currently teaches both in the BSCN and the practical nursing programs in the simulation environment. She also coordinates the second year BSCN program. Deb obtained her Master's of Health Science and Health Promotion from the University of Toronto and her BSCN from McMaster University. So welcome to the two of you. We're really excited for your talk today. And as I was saying, there's this concept of virtual and asynchronous learning really fits not just on point with our environment today, learning environment today, but with some of the digital transformation initiatives that we're going through at the college. So with that, I'll turn it to Deb and Stephanie.
Thanks so much, Mira. So yeah, I guess this project was somewhat precedent as we conceptualized it through 2019, collected our research in the fall of 2019, and then we're just doing data analysis through early 2020, and then we all know what hit. So we were fortunate to get this, collect our data and get the work moving along quite nicely so that we could get close to, get the publishing process happening. So that sort of gives you a little bit of a timeline. It was published in early this year in the Clinical Simulation and Nursing Journal. And Stephanie and I were, for the project, primary investigators. And we also worked on our team was Marian Luchter-Flood and Jane Tyerman. So we had the privilege of working with them together as a team on this project. So our interest was in virtual asynchronous debriefing, and we wanted to know to take a look at it in relation to face-to-face debriefing to support clinical decision-making in relation to using a virtual simulation game. The picture on this slide you see, this is Betty, and she's delivered a newborn in a clinical setting, and this is part of a virtual simulation game that students go in and work through as part of this project. So the game itself was developed by Centennial, the partnership of Centennial College, George Brown College, and Ryerson University, and it's free access, and it's just a wonderful game. So the other thing I would like to say is we'd like to thank RISE for the funding grant for this project. So it was instrumental in helping us get this off the ground and published. So thank you. Next slide, Stephanie, please. This is us. So that's me and Stephanie, who you see us in the video as well. So, so we're co-primary investigators. So next slide, please. So today's learning outcome for the session, we're hoping that you'll be able to describe the impact of a virtual asynchronous debriefing strategy following a virtual simulation game, or VSG, on nursing students' perceived anxiety and self-confidence for engaging in clinical decision-making. And in the little picture there, you can see this is another clip from the game, which is an actual nursing intervention following a part of the decision making that they have to do. Next slide, please. In terms of background, so I'd just like to set a bit of background for you around some of the concepts that we felt were important and related to this project, and sort of the foundational theoretical concepts that we based it on. So first of all, clinical decision making, or CDM, this is an essential skill for nursing students to develop. And that's been shown time and time again in literature. There are 4 accepted domains of clinical decision making. And the first is recognizing the patient cues and being able to identify related problems or predictive problems. And then moving on to interpreting and prioritizing the cues for relevancy. So sifting through the cues that or clues that are presented to you in the patient case and the patient scenario, and then identifying, are they relevant and are they salient? And then integrating the assessment findings and identifying what possible options may be available. And this is sort of seeing a whole picture and being able to use whatever resources may be available, or identifying the resources that may be appropriate. And then finally is performing an intervention and then reflecting on the selected action that was done. So sort of an evaluation at the end of this. We know that effective clinical decision-making skills are really strongly linked for competent and safe nursing care. So that's something that we felt very strongly about accessing and looking at in this study. So next slide, please. We also know in terms of clinical decision-making that it's influenced by a couple of factors, namely anxiety and self-confidence. So anxiety can actually be an emotional barrier to the ability to effectively engage in clinical decision-making, whereas self-confidence actually supports the ability to be effective in it. And it affects the ability to consider the best options and, you know, having the confidence to be receptive to patient cues and see them within a broader context. And when one has the self-confidence, they don't tend to be distracted by their own anxieties. So they're able to more clearly see the bigger picture and identify and sort of work through the clinical decision-making model. Next slide, please. Thank you. So given what we know about anxiety and self-confidence, that guides educators in terms of knowing that the importance of fostering a safe and supportive environment where students can practice and they have a better chance of developing good competency with clinical decision-making. And one option for that is a simulated learning experience or environment. And we know that that has been linked to being able to enhance that development of the clinical decision-making. So in those environments, we are able to control for more situational factors and set the environment up for psychological safety that can support the development and engagement and self-confidence and lowering anxiety. Next slide, please. In terms of simulation, and this is both live and virtual because both do exist, it supports students to gain that self-confidence and lower their anxiety, as I mentioned earlier. Virtual simulation games are sort of another evolution of virtual simulation, and they're being used to support learning and really help students prepare to enter the clinical setting. And they are an alternative to face-to-face simulations. And I'll explain a little bit more next about what virtual simulation games actually are. Next slide, please. So virtual simulation games also present a real clinical scenario and present options for the learner or the person who's engaging in that simulation. They have options that they can select from, and depending on what they select, it moves along to a different patient response or a different situation, part of the situation. So the scenario evolves with each response from the learner. It also requires the learner to apply their nursing knowledge. So they have to assess the situation by interpreting whatever clues they're finding from either what the patient says or how they present or what's present in the situation. Then they need to make a decision based on how they've prioritized what clues they've encountered. And then they go on to selecting nursing actions for the virtual patient. So what actions are actually relevant to what's salient in terms of what the cues that they were presented with, and this is all as the scenario evolves. The VSG is linked to increasing student engagement and critical thinking. It's a very engaging way to learn, and students are really primed to engage in gamed learning. They love it. They are really able to identify where they chose a wrong answer and why at the end of it. So it's very effective that way. There is, in terms of VSG and learning, there's a critical link between any VSG or simulation or simulated learning and the debrief. And that's the key, is the debriefing strategy in terms of drawing the learning out from that experience. So let's talk a bit about the debriefing in terms of the significance of it to this study. So next slide, please. Thanks. Debriefing following simulation is identified as best practice. And this is in the INACSL, the International Nursing Simulation Group. In 2016, they published a number of best practice guidelines, and it's just essential piece of debrief of learning that promotes learning after a simulation. It really guides the reflection of the learners on what happened in the simulation. And it also, when skillfully done, can lead to new interpretations in really reframing how the simulation, how the choices that were presented by the simulation, the cues that were presented, were interpreted by the individual. And that leads to learning when we can reframe that if that was incorrect at the time. It also helps participants become more self-aware and develop more self-efficacy. What's important is that the debriefing follows a structured theory-based format, and it really guides the students through those, engaging with those domains of clinical decision-making. So let's, next slide, please. So the model that we used for debriefing in this project was the 3D debriefing model, and it has been used in virtual debriefing, self-debriefing, and in-person debriefing contexts, and been shown to be very, very efficient and effective at promoting learning. It consists of 3 phases, so hence the 3 Ds. There's diffusing, which is really discussing the impact of the simulation. So how did that feel to you? Sort of getting through those emotional initial responses to the events of the simulation. So we can kind of get that out in the open initially, so it doesn't interfere with the deeper learning that may happen in the next step. It also reviews the sequence of events. The next piece is discovering, and that's where learners review and analyze their own performance. So when this clue was, or these 3 clues were, or cues were presented, which one did you feel, or which one did you believe was most important or most salient, and why did you believe that, and then how did that lead you forward? So it's really helping them understand what their mental model was and whether it was correct or not, or helping them just re-understand what their thinking was and the rationale. And then there's deepening, and that really helps students connect with a new mental model. So setting up, okay, let's clarify, or let's identify the correct thinking through that scenario, and then let's reframe, let's try to reframe that so that going forward in future practice, that's something that you can go through. So it's really a process of correcting and then connecting to future events and future practice. Now, next slide. So at this point, so there is limited research about best practice for debriefing virtual simulation games. And we also don't have a lot of knowledge in the literature around understanding whether asynchronous debriefing supports learning in the same way as a traditional face-to-face debriefing. So that's where we wanted to really explore that. So next slide, please. So the purpose of the study, to drill down, was to explore how students perceived anxiety and self-confidence for engaging in clinical decision-making was impacted by a virtual asynchronous debriefing strategy following their engagement in a virtual simulation game. So next slide, please. Given that was our larger purpose, we had two research questions. And the first one was, what is the perceived effect of a virtual asynchronous debriefing method following a virtual simulation game on students' self-confidence and anxiety for engaging in clinical decision-making process? And then the second research question was comparing the two strategies. So how does an asynchronous debriefing strategy compare to a traditional face-to-face debriefing strategy in supporting student engagement with the clinical decision-making process? Next slide, please. In terms of developing the theoretical underpinning for this research, we really felt cold. So the experiential learning theory fits so beautifully with simulation and has been used quite a bit in research in the past in relation to simulation. And it also we were able to map that, as I'll show you in a minute, to our protocol quite nicely. So you're all probably familiar with the experiential learning theory. I'll just quickly go through it. Often you start with a concrete experience, so doing or having had an experience. So this would be the student engagement in the virtual simulation game. Then there's reflective observations, so your opportunity to really review and reflect on that experience and what your performance was like and how that felt for you. And then the next stage is abstract conceptualization, and this is sort of what learning occurred for you from the experience. What new understandings can come out for you around it. So it's just exploring all of the events that happened, the mental models that were being enacted in that situation, and what needs to change from those. So it's really extracting that learning from there. And then the last phase is active experimentation. So it's, okay, so you've learned something from that. Now let's go try it out again and see how that works, and we can go around again, hopefully on a different level. So that's basically the 4 stages of the cycle. Our methodology, so this was our design. It was an experimental 2-group pre-test, post-test design. It's pretty small type there, so sorry about that, but I'll just run through the protocol with you. So we had all students in terms of the concrete experience level and engaged in pre-simulation preparation. So they did some readings, they created some cue cards, and then they went on to complete the virtual simulation game just prior to their week that they were coming into the experience in an OB Sim lab. So the actual hands-on experience in that setting. So they knew coming into the study, coming into this game, that they were going to be going into a hands-on experience in the lab. They were expected to print off a performance summary from that. And that's where that whole concrete experience was. Their next step was to complete a self-reflection referencing this performance report and reflecting on how their process in the game went. And this was to be done within 12 hours of completing the VSG. They then all completed the measurement tool, and Stephanie's going to be talking more about that measurement tool, which looks at their ability to engage in clinical decision-making, their self-confidence and their anxiety, looks at that as well. The students were then separated into 2 groups randomly. So we had one group that would go in to, on Blackboard, we had set up a a virtual discussion board where they were guided through with a series of structured questions using the 3D model of posts. So they were doing some reflection, engaging in some debriefing using these questions. They had to post 2 posts at a minimum. So one was their initial response about the experience in relation to the questions that were asked, and another was a response to someone else. And this was, there were comments made by faculty who were monitoring this chat as well. So they then finished being online, then they came into the sim lab for their experience. At the very beginning of the sim lab, they completed the tool once again, and then they continued on into engaging in active learning in the live scenarios. The other group was the face-to-face group. And what they did was they completed that tool. They then came into the OB Sim Lab where they had face-to-face debriefing at the very beginning of the Sim Lab experience. Then they completed the tool again, and then they moved on into the active experience of the actual Sim Lab. The students in participating in this entire project received a 1% mark for completion of everything. And that was approved through ethics. Next slide, please. And I'll hand it over to Stephanie at this point.
Thank you, Deb. So the study took place in a school of nursing that was located in southwestern Ontario. The participants for this study were practical nursing students, and they were in the 3rd semester of their program, which would be year 2 of their program. And those that were participating were also completing as part of their coursework, their obstetrical learning class. So those are the individuals that were participants in this study. Okay, and like Deb said, we used a demographics questionnaire, and we also used what we would call the nursing anxiety and self-confidence with clinical decision-making scale. Okay. So the demographics questionnaire was only completed at the first time, and then at both data collection points, the students completed the nursing anxiety and self-confidence with the clinical decision-making scale. So that scale measures perceived levels of self-confidence and anxiety in nursing students as they progress through the clinical decision-making model. It's a 27-item, 6-point Likert type questionnaire. And it has 2 subscales. So it has a subscale for self-confidence, and it also has a subscale for anxiety. And then within each of those 2 subscales, there's 3 dimensions within each of those. So the different dimensions that we call D1, D2, and D3. So D1 relates to data gathering. So within this subscale, it was assessing really the student's perceived ability to listen, to use resources to gather relevant data that is going to then inform their nursing care. Okay, D2 subscale is really seeing the big picture. It's their ability to use information to see that big picture, to feel confident, to see the patterns in the data that they have and the relevance of the information that they've collected, and also to be able to recall previously learned knowledge, to be able to apply it and integrate it into their analysis of seeing that big picture. And then the last subscale, the D3, is knowing and acting. Excuse me. So that's the ability to really know and act within the clinical scenario. So when they get to the clinical scenario, do they know what nursing action to select? Do they know how to proceed with the client in that given case? So in this part, they need to analyze those risks and benefits of all the different nursing interventions that they could select. And then they need to be able to select the best nursing action for the scenario. So these are the 3 dimensions, and these would align very, very closely with the nursing process that we use as nurses to sort of move through clinical decision making. Okay. Convergent validity and internal consistency of the scale has been tested and established as well. So in terms of data analysis, we had chi-squares and independent sample t-tests, pair t-tests, and a 1-factor repeated ANOVA to analyze the data in relation to each of the dimensions and in relation to each of the time points. We also conducted descriptive statistics of the questionnaire, demographic questionnaire, okay? And all of the data analysis occurred within SPSS software. So in terms of our findings, we had a participation rate of 78%. So of a possible 82 students that participated in that class and that were eligible, 64 of them decided to participate in our study. And somehow we ended up with 32 in the face-to-face group and 32 in the asynchronous debriefing group. So there was about 50-50 in each of the debriefing strategies. What we did find through our findings was that the two groups were comparable in terms of all of the demographic variables of things such as gender, employment, either as a personal support, PSW or unregulated care provider. They had similar post-secondary experience as well as age. Okay. So we really did identify that the two groups really were comparable before the intervention in relation to all those demographic variables. So there really was no significant difference between the groups on any of the subscales. But we did that. There's no difference between the groups on the subscales except for our D1 subscale of anxiety, suggesting that what we did find is that it would suggest that the asynchronous debriefing strategy had a greater influence on decreasing student anxiety in relation to the D1 as compared to that face-to-face group. Okay. The paired t-tests evaluated the impact of the intervention on the student's score of self-confidence and anxiety. Both groups did show to have an increase in self-confidence and a decrease in anxiety scores for each of the three dimensions from time 1 to time 2. Okay. What we did note was that all of the asynchronous groups changes were significant, while only the D2 for self-confidence and D3 for self-confidence and anxiety for the face-to-face group were significant. But what is really, really important to note is that all the dimensions moved in the expected direction that we would have expected. So we would expect, and we were hoping, that engaging in a debriefing strategy would increase self-confidence and decrease anxiety in relation to clinical decision-making. And all of the changes in relation to our findings demonstrated that did occur as expected. So both have really enhanced self-confidence and reduced anxiety in relation to supporting students to select and implement actions within a given clinical scenario, since that was the one that was most significant. A one-factor repeated measures ANOVA identified that there was a statistically significant effect for time, okay, suggesting that there was a change in self-confidence and anxiety scores across the two different time periods. The two groups did differ in terms of their change for D1 anxiety dimension, which is the ability to listen and use resources to gather relevant data to inform care. And this would suggest that the asynchronous debriefing strategy had a greater impact on reducing anxiety in relation to D1 than the face-to-face group. However, both strategies improved self-confidence and anxiety in relation to clinical decision-making. So in terms of just a summary of the findings, we really did find that both strategies demonstrated to increase self-confidence and decrease anxiety for clinical decision-making. So they both are good options for supporting the development of this learning, okay? All of the dimensions in relation to asynchronous debriefing demonstrated significant changes, while only D2 for self-confidence and D3 for self-confidence and anxiety for the face-to-face group were significant. Okay. Asynchronous debriefing may have had a greater influence on decreasing anxiety for D1, which is the ability to listen, use resources to gather relevant data, as compared to the face-to-face group. But what's really, really important is that in both groups, the D3, which is really being able to know and act, so to be able to engage and know what to do in a clinical scenario, both of them showed significance, and actually the face-to-face group actually showed a higher level of significance for self-confidence in relation to that dimension. Okay. And in particular, both demonstrated particularly to impact that D3 dimension, which is knowing and acting, which is really, the end goal for students is to be able to take that knowledge and know how to act within the clinical scenario. Okay. So really some of the the main conclusions that we really found is that we really did confirm that debriefing is an important opportunity that really influences the development of self-confidence and the reduction of anxiety for engaging in clinical decision making. And we really would support that it should be used with virtual simulation gaming to support that learning. Okay, we really saw that the asynchronous debriefing strategy significantly reduced perceived anxiety and increased self-confidence in relation to all 3 dimensions. So it is through our findings has demonstrated to be an effective strategy to help work through the process of clinical decision making. While the results suggest that the asynchronous debriefing strategy more effectively supported self-confidence and reducing anxiety in relation to all steps of the nursing process, it is really important to note that both strategies supported that D3 again, which is being able to know and act within the clinical scenario. And some of the differences that we saw, what we've reflected on, that the differences may relate to the differences between the debriefing strategy. An asynchronous debriefing strategy required participation by all students in the form of reflecting and debriefing on the questions. And they were required, each and every student, to compose a written response to the reflected debriefing questions, which may further have supported their engagement in that debriefing process. Whereas sometimes in face-to-face debriefing, active participation by all and every single student is not always required. Some students, I tend to see that some students may be more active than others and participate more fully, where others are more passive sort of learners in that process. And so it may be in relation to sort of just the differences between those 2 debriefing strategies. Okay. The other thing that we think it may be linked to as well is that the asynchronous debriefing occurred just sooner after the completion of the virtual simulation game. So this may actually have impacted the student's ability to sort of remember, to re-examine, and to make sense of that learning that occurred, as opposed to the face-to-face group that waited until they came back to class. Now, it wasn't a large difference between the amount of time, but it is a little bit of difference that could have impacted their thing. Okay. And then one notable finding too in relation to the face-to-face group was that significance was only really seen in relation to D3 knowing and doing. And we don't know whether the lack of significance that we didn't see in the D1 and D2 areas will actually impact their accuracy or ability to perform and engage in that final D3 dimension of acting and knowing in clinical decision making. Okay. The other thing that we maybe have linked some of those findings to is that the lack of changes for the D1 and D2 may be linked to the fact that students are novices, and that confidence in one's skill and recognizing and interpreting may actually come with continued learning and experience. Okay. And two, I think, the asynchronous strategy may have also just provided more time and actual opportunity for students to sort of engage in some of that process. And they would also, during the asynchronous, have had even the opportunity to consult relevant resources, right, to support that post that they need. So those are some of the key findings and conclusions that we made from our study. In terms of some of the limitations, it was a smaller sample size. So always, a greater sample size is going to increase the reliability and validity of results. But we did reach the sample size that was needed for parametric testing. The other thing is that the questionnaire is the student's perceived ability to engage in clinical decision making. So sometimes we don't know whether the perceptions may be a reliable indicator of their actual knowledge and skill in relation to clinical decision making. And then the last limitation would have been that one of the researchers was present in the simulated environment, although they were not responsible for any student evaluation in relation to the course. But they were there and collecting data, so that may have impacted the results. And then just one more acknowledgement that I did want to make was just Wilma Hoopman from Queen's University and Richard Ronaldo from Georgian College. I just wanted to again thank them for their contributions to the statistical analysis as they were instrumental in supporting us. Thank you. Yes, where we can ask or take the chat.
We have, for sure. We have a few questions, some really good questions, Stephanie, from the chat. So I'll just start from the first one that was entered by Mira. Thank you, Mira. Are students encouraged to make the wrong decision just to see what the outcome might be as another angle to learning? Yeah, and I think that's actually inherent in a game structure is you can play it as many times as you want to. And in this game, you select the wrong answer, it pops you back to that same stage where you can select a different answer. And there is inherent learning because each wrong answer is given a rationale. So, you know, students, when you debrief with them about you doing the game, that triggers learning, and that's what they talk about is, wow, I chose the wrong answer. This is why, this was what I was thinking. And it told me this as a rationale. So then you explore that a little deeper. I think also your question there links to, I think Jacqueline's got a question about new research questions from the study. And I think there's an opportunity to look at sort of the inherent learning that happens within the game structure, as you know, in comparison to the learning that might happen through a debrief at the end. I think there's really some interesting questions in there. Stephanie, do you have anything to add to that?
No, I think you answered that quite well. And I think like the nice part about the fact that the game will bump you back to the same question again is that sometimes students, they'll think that the client might respond in a particular way, but until they, again, see how that response plays out, it kind of makes it more real life for them. But I think too, it creates a safe environment that sort of supports simulation because they know that they have that opportunity to correct those errors. And students can do the game as many times as they want to. So that really supports it as well. In terms of new research questions that emerged, I think just, you know, looking at different virtual simulation games and just even different debriefing strategies, you know, we used, you know, a minimum of 2 posts and things like that, but just trying different structure in terms of how the virtual or asynchronous debrief is run could be something just to sort of perfect that style of debriefing as well.
I think too, something else, and we had talked about this in terms of the protocol, was we would have loved to have done another measure, like a third measure at the end of the simulation experience, the hands-on, just to see if there was a difference between the 2 groups after having had that experience. But we just felt that it would just get too unwieldy for us. So, but that would have been interesting, I think. There was another question from Kevin. Thank you. Are the 2 debriefing strategies similar with respect to time needed from the instructor? And just to respond to that, it was hard to determine that because the debriefing face-to-face was a fixed time, like 1 to 8, right? We're all together for about 20-30 minutes at the beginning of the class versus interaction sprinkled through responding to individual posts versus responding to an entire group. So I think it's quite comparable. I wouldn't say one was any more than the other.
That we wanted to do this study too is a lot of the literature really suggests just, the number of resources that are needed for simulation and the time commitment. So asynchronous debriefing sort of helps to sort of mitigate some of those challenges. So it was sort of nice to see how you could pull the debrief out of the classroom setting and face-to-face to open up perhaps that time for something else as a way to support learning in that area, VSG, without taking it into the classroom.
One thing we did seriously consider was the time commitment on the student side for the 1% grade. So we wanted to make sure that it was comparable and that the amount of work that they were doing for the asynchronous debriefing was comparable to what they would be doing in the face-to-face. So there's another question. Do you measure or notice any correlation to preferred learning styles, e.g. visual, auditory, reading, writing, and kinesthetic? I'd have to say that wasn't in the scope of our study. I think research has shown that nursing students tend to a preference for kinesthetic generally as a group. That may not be a fair generalization, but I don't know that I can really answer that question.
Yeah, I don't think we can make a conclusion because as part of our study, we didn't measure and identify individuals.
But that might be interesting for another time to,
Yeah.
to take a peek at that. So. And then do you know if this virtual asynchronous debriefing strategy is used in other programs, practices, areas of teaching? I'm thinking of co-op and all the other programs that have service learning or field placements. My response to that would be, you're always bringing the debrief, like the debriefing is structured. And then you're always bringing the debriefing structure, layering that on top of the learning outcomes for the experience. So, and you're kind of moving back and forth between the two to make sure that there's awareness of meeting and working toward those learning outcomes in the experience. So, asynchronous could certainly, I would think it would be worth a try in a co-op situation in a structured way.
And I think too, what we see is particularly within nursing, the virtual simulation gaming is actually, it's being used more and more. And I think what our research really does suggest though, is that, you know, to just assign it as a student activity and then to not debrief on it doesn't help students to move through that process of clinical decision making. So I'm hoping that our research will sort of support even for use in nursing, but other professions, that, you know, it needs to sort of be paired with that debrief so that the instructor and the student can sort of collaborate to sort of make meaning of that knowledge. Mm-hmm. Any other questions? Oh, one new message. Oh, thank you.
Very interesting. Yeah, it's absolutely interesting. And I think, as I mentioned, you know, before you started talking, you know, there is a movement for digital transformation, you know, these simulations, learning remotely. We had a conversation before you're even talking, even this on-demand learning, right? So when you think about asynchronous, it is incredibly relevant. And I think this research is really pioneering how not just Georgian, but other post-secondary teaching programs or learning programs can benefit and support their students, not just for clinical practice, but for learning and reinforcing learning in general. So what a great research project this is. Yeah, everyone's saying thanks so much, Deb. Sarah Lang, she's saying very timely research with applications to many programs beyond health. And that's just exactly it, like beyond health. In any sort of environment where students are doing simulations, you know, I work with the technologies a lot, and there's a lot of simulation activities happening, or learning, or VR learning happening in the technologies, engineering technology. And it's the same concept about, you can do the simulation, but you don't really reinforce the learning until you've had a chance to think about it and debrief on what you've done. So it's the research is incredibly on point. So thank you very much.
Thank you.
Yeah. So with that, if there's no other questions, I'd like to thank everybody for joining today. I'd really love to thank mostly thank Stephanie and Deb for presenting this research. Deb, you mentioned the Research Innovation and Scholarship Fund that helps support this research, and thank you for doing that. And I bring it up now just because there is another call for proposals that was released onto Staff News, and we'll put a link here in this Zoom as well for folks. But we are accepting applications for the next round of proposals for the Research Innovation and Scholarship Fund. And just look what a small bit of money has allowed Stephanie and Deb to accomplish. So looking forward to folks seeing how that fund can be used for their own work, their own research and scholarship work. Last note is we do have another speaker lined up for next month, Sarah Hunter. It will be talking about some of her NSERC funded research with the Waypoint Center for Mental Health Care. It's related to COVID-19 as much as these days, and the focus of her research has been about online mindfulness program supporting healthcare workers at this time. So with that, thank you again for joining. Thank you for your presentations and Research Innovation and Scholarship Fund proposals, and have a great day.
Thanks, everyone.
Thank you so much for coming, everyone.
Thank you.